2014, Associate Professor of Neurology at CMC Ludhiana, Dr. Vineet Jason. After completing his undergraduate, post-graduation, and his neurology training at the prestigious CMC Ludhiana, he climbed up the ladder gradually from being senior resident to where he is now as associate professor in the Department of Neurology. He's done a number of observerships in Australia, including ones at Austin Hospital, Melbourne, Royal Brisbane Hospital, Brisbane, Westmead Hospital, New South Wales, etc. And he has also attended observerships at Sri Chitra Tirunal Hospital in Trivandrum and also at the prestigious CMC Ludhiana, CMC Vellore. He presented the paper on does CT angiography spot sign predict hematoma expansion and outcome in early primary intracerebral hemorrhage, an interim analysis at the World Stroke Congress in Istanbul, Turkey. And for that, he was given the Young Neurologist Award. Principal investigator and co-investigator in 4 clinical trials, 5 international and 4 national papers presented, 8 publications in peer-reviewed journals behind him. Dr. Vineet has initiated and currently is managing a multidisciplinary neuromuscular clinic, organizing and helping to set up the neurointerventional suite. He has also set up a rural neurology clinic in Punjab. His exemplary clinical work is really famous in the area, and his areas of interest include neuromuscular disorders, neurorehabilitation, and neurodegenerative disorders. So it's a great privilege to have Dr. Vineet Jason, Associate Professor of Neurology, CMC Ludhiana, with us. Welcome, sir.
Thank you. Thank you for having me here.
And to moderate the session, we have our senior consultant neurologist and head of the Department of Neurology, Believers Church Medical College and Hospital, none other than Dr. John K. John, sir. After completing his MD General Medicine at Trivandrum Medical College, he went on to do his DM Neurology at Calicut, and his areas of interest include epilepsy, multiple sclerosis, and neuromuscular disorders. He was previously the Associate Professor and Consultant in Neurology at MOSC Medical College, and went on to Kuwait and worked in the Ministry of Health as Consultant Neurologist. He also did a great job as Assistant Program Director of the Kuwait Institute of Medical Specialization and was the Chairman of the Examination Committee for the Neurology Residency Program. A luminary in neurology, it's a great privilege to have him to moderate this session. Sir, welcome. Now, may I hand over to Dr. John K. John, sir, to introduce the session and hand over to our speaker, Dr. Vineet Jason. Over to you, Dr. John K. John, sir.
Thank you, Dr. Jacob. Am I audible?
Yes, you are, sir.
Yeah. Good evening. It is my proud privilege to moderate today's webinar. The topic is clinical diagnosis in neurology. In this modern era of technology, when people often, and even doctors, discuss about artificial intelligence replacing the role of doctors in diagnosis, I believe this topic is very relevant. I'm sure as practicing physicians, we all have experienced that we are in dire straits, even with all the investigations like MRI, DAT scan, PET scan, and whatnot, unless we have a proper history and a proper clinical examination. For example, in neurology, in some conditions like movement disorders, and sleep disorders, sometimes history is more important than even examination, clinical examination. And almost always, otherwise, the clinical localization by proper clinical examination is also so important. To quote a simple example, in a patient who is having GBS in the early phase, to differentiate from myelopathy, with all the investigations, it's not so going to be so difficult unless you have proper clinical examination. So I'm sure it will be a very interesting session today. I'm sure you will all enjoy Dr. Jason's talk. Meanwhile, I also request you to put in your questions in the chat box so that we can have a detailed discussion at the end of the session. Over to you, Dr. Jason.
Thank you, Dr. John K. John. It's a privilege for me to be here and to give this talk. And good evening to everyone who's here and who's listening. So I'll just share my screen. Is my screen visible?
Yes, yes.
So I'll begin with a simple case. As a 47-year-old man was brought to the emergency room with recent onset inability to move his right arm and leg. And they found that he had not been speaking for the last 2 days. And on examination, he was lying comfortably with the angle of the mouth deviated towards the left, and his right arm was by his side, and his right leg was externally rotated. And also, he seemed to be moving the left side of his body. Unable to speak or follow simple commands, he was looking to his left throughout the examination. This is a very common case we come across in our emergency room. And based on this, there are a few things that jump to our mind. But I would like to take you through a process that will help us to think about this case more holistically and realize that the answer is not what strikes us immediately. And we need to explore things even more deeply. So, clinical diagnosis. Here we have a patient who has a history, a very brief history, and examination. So, how do we go about making a clinical diagnosis, and what actually is a clinical diagnosis? So, a clinical diagnosis, according to the National Cancer Institute, is the process of identifying a disease, a condition, or injury based on the signs and symptoms of the patient that the patient is having, and also the patient's health history and physical examination. Now, this cannot be emphasized more. Like Dr. John just mentioned, that a clinical history is key. And very often, that can be the main differentiating factor between a right diagnosis or a wrong one. I would like to put it saying that it is a logical conclusion that is derived after following due process of a detailed systematic study of the patient's history and physical examination. Why is this important? There are two words here which are very important. That is the word logical and also the word conclusion. The emphasis here is on the fact that after taking a detailed patient's history and conducting a relevant physical examination, the application of logic is very important, and to be able to summarize what we have found. As doctors, our primary responsibility after doing a good history and examination is to be able to come to a reasonable conclusion at the end of it. Even in medical legal terms, from for people who would be examined by the court, our responsibility ends if we had applied logic. So, coming to the fact that despite applying logic, can our clinical diagnosis still be wrong? Yes, of course, it can be wrong. If the patient's history was wrong, which means that the patient's historian was unreliable, didn't give us a proper history, or if the history was incomplete, or the patient, when he presented, was under the influence of some substance and there was no accompanying historian, then we can go wrong. But however, the blame does not lie at our end here. Physical examination, on the other hand, is something that is entirely in the hands of the clinician. And the clinician needs to develop skills which comes with practice and over time to be able to develop skills at the bedside to diagnose. So coming again, a clinical diagnosis is a logical conclusion that is derived after a detailed, systematic study of the patient's history and physical examination. What are the parts of a clinical diagnosis? A clinical diagnosis has three parts. There is a syndromic diagnosis, which basically is a constellation of the signs and symptoms that a patient has, which is being put into clear brackets where these patients are having these symptoms. And each of these syndromic diagnoses points towards the anatomical localization. This is the history and examination would point to one particular part of the neuroaxis. And once we have localized it to one or multiple parts of the neuroaxis, then it is our responsibility now to consider what pathological possibility, what could have caused that particular problem in that neuroaxis. Without any of these things, if any of these things are missing, then our clinical diagnosis is incomplete. And it is very important for us to follow the process of going from a clinical systematic of history and examination, forming a syndromic diagnosis, on to, in our brain, in our mind, localizing it anatomically, the sites possible that could have caused that syndrome, and also considering the etiological possibilities or the various pathologies that can affect that part of the neuroaxis. Briefly, we need to review the neurological anatomy, and that would be the first place to begin, really. If we are strong in our neuroanatomy and we understand how the brain and the spinal cord and the nerves work intricately, then we also know the various syndromes each part can cause. And that really makes the job very easy. As a doctor, as an MBBS doctor, or as a physician, if our neurology anatomy is good and strong, then our syndromic diagnosis is very, very simple and straightforward. So there are two parts of the nervous system. You have the central nervous system containing of the brain and the spinal cord, and then you have the peripheral nervous system, which begins from the roots. You can say the anterior horn cells within the spinal cord and the roots, and of course the plexus, the nerves, the neuromuscular junction, and the muscle. Here I have just kept a photograph of the brain, and we see that the brain is such a beautiful structure, and the brain has got four lobes. You have the frontal lobe, the parietal lobe, the temporal, the occipital lobe, and you also have the limbic lobe. You have the distribution of certain body parts on different parts of the brain. For example, you have in the motor homunculus, you have the face and the arm on the lateral aspect of the brain, while the foot hangs over the medial aspect. Similarly, in the sensory homunculus, you have the face and the arm over the lateral aspect in the parietal cortex, and then you have the leg that hangs over the medial aspect. And that's very important, that there is differential representation of certain body parts, which is helpful when we are looking to localize which part of the brain is getting affected. Coming on to the cranial nerves, we all know that we have 12 cranial nerves, and these cranial nerves two come out from above the brainstem, two come from the midbrain, and then four comes from the pons and four from the medulla. And that makes it very easy for us to think of them in order from 1 to 12, and different kind of pathologies can affect them. But briefly, just to mention here that we have 12 cranial nerves, 12 pairs of cranial nerves on either side, and they can be affected. And if they are affected within the brain parenchyma, they will also have other long tract signs like the corticospinal tract or the spinothalamic tract or any of the other long tracts which are traveling through the brainstem near these cranial nerves, whereas they can be affected in isolation if they are outside the brainstem. So these are the 12 pairs, just to make it very simple. So you can have one cranial nerve affected here, you can have another one affected here in different combinations, or they can be affected contiguously in series. All of that points towards different anatomical localization. Coming below the brainstem, we come to the spinal cord. It's a very intricate structure protected by the vertebral canals, and the spinal cord travels from the cervical dorsal up to the lumbar area, and there it gives away to the roots all across all the segments. Below the lumbar area, you have the cauda equina, which is the clumping of all the roots here, and the cauda equina, which we will come to why that is important. Within the spinal cord also, we know that there is a laminar arrangement where the motor anterior horn cells are situated here, and you have the sensory tracts that are traveling posteriorly, and also the spinothalamic tracts that travel laterally. And the spinothalamic tract, they cross over at the level, whereas in the posterior column, we know that they don't cross over, and then they go straight up to the lower part of the midbrain at the sensory decussation, and then they cross over to the thalamus. So this is very important when we look at spinal cord disorders, whether they are affecting the hemicord, are they patchy involvement, are the diseases affecting only the anterior horn cells, or they're affecting the posterior column. So anatomically, it's very important to know how they are arranged. Coming on to the corticospinal tract, the motor system. So corticospinal tract begins in the cortical neurons, the motor neurons up in the cortex, and then they come together at the internal capsule, and they travel down the midbrain, come down to the pons, and then they cross over at the medulla in the medullary decussation. We call it the pyramids. And here, when they cross over, a majority of them, they then supply the midbrain, they supply the anterior horn cells, and they travel as the lateral corticospinal tract, and they supply the anterior horn cells at different levels and cause voluntary motor action. This is another diagram illustrating the same point on how the corticospinal tract, they travel down. We have the corticospinal tracts that come down and they cross over at the medullary, the pyramids, and then they travel down into the spinal cord and cause involvement of the opposite side of the body. We also have an interesting phenomenon where we see upper motor neuron type of diseases, which are diseases that are affected because of involvement of the corticospinal tract. When the corticospinal tract is a tract that actually, to a great extent, inhibits the anterior horn cells. And this corticospinal tract, when it gets affected, there is certain syndromes that we see in which there is brisk reflexes, there is spasticity that sets in, and there is also clonus, and we get to see the Babinski sign in patients whom the corticospinal tract is damaged. At the same time, if the lower motor neuron, which basically is the anterior horn cell, which travels from the anterior horn cell out to the ventral root all the way down to the nerve and into neuromuscular junction, if there is a damage to the lower motor neuron, then the patient faces flaccidity, areflexia, wasting, and these are basically because the anterior horn cell is a final common pathway, which can be seen here. There are several tracts which are influencing the anterior horn cell. It is not only the corticospinal tract. And when this anterior horn cell itself is destroyed for whatever reason, it can be the neuron or the axon, then the patient develops symptoms that are suggestive of with lower motor neuron weakness, which would mean what I said with atrophy, flaccidity, hypotonia, plantar reflex may be normal, patient may have fasciculations. All of these things are seen when there's involvement of the anterior horn cell and the rest of the axon along with that. Now, spinothalamic tract and the sensory component, like we briefly mentioned, the spinothalamic tract would travel from the skin and from all the receptors all the way back into the posterior part of the gray horn, and from then they will cross over and they travel along the spinothalamic tract only to in the thalamus they will come, and from the thalamus they go back to the cortex, the sensory cortex. And the posterior column, on the other hand, it travels on the same side and it crosses over at the sensory decussation in the medulla. Just sensory decussation is just proximal to the motor decussation at the medulla, and then it crosses over onto the opposite side. This is a diagram of the posterior column, how it comes, and it goes in the same in the medulla. Here which I had shown previously. So various patterns of involvement can be seen and in the spinal cord, especially because the spinothalamic tract and the posterior column are situated a little far away from each other, although they may be just a few millimeters away. There can be diseases that selectively affect one or the other, which we need to know so that we can clinically diagnose these conditions. This is a diagram just to show how the spinal cord would come down all the way till here, and then they form these roots which travel out of the vertebral canal, and they form a plexus here, and these are the roots that are the thoracic roots, and then you have the lumbar plexus and sacral plexus, and they form nerves, large nerves which would go down. Now each root that we know, the ventral root and the posterior root, the ventral root basically has the motor axon, and the posterior root carries the sensory axon. Most of them would be carrying sensations from the skin, some would even carry sensations from the muscle and from the joints. And then we have various plexuses. We have the brachial plexus, we have the peripheral nerves, and within the nerves we have different types of fibers. You have the large heavily myelinated fibers that carry fast sensations like touch, pressure, and then you have small thinly myelinated fibers that carry pain and temperature, and the small unmyelinated fibers that may carry slow pain and temperature. Now, this is also important because there are diseases that can affect different types of nerve fibers. And that is important for us to know that when we make a clinical diagnosis. Similarly, lumbar plexus, we have the lumbar plexus that comes out from L1 all the way down to the L5 and the sacral plexus below it. And they come out and form roots, which we come out from the plexus, they form nerves, and individual nerves supply different muscle groups which can be clinically diagnosed. And then they form these peripheral nerves which go down and supply the leg and the foot. Each of these nerves, these motor nerves especially, the motor nerves, they end in a neuromuscular junction. And the neuromuscular junction basically comprises of the nerve end, which is called the presynaptic area, and we have the synapse in between, and we have the postsynaptic area, which is basically the muscle membrane. And this neuromuscular junction releases chemicals, which is basically acetylcholine, and triggers action potentials in the postsynaptic membrane. And this would then, of course, cause involvement of the muscle and cause muscle contraction and causes movement. That's how all skeletal muscles work in the body. Quickly, just to recap a very important part, and that is the spinal reflex. Here you can see this diagram, which basically shows that there are sensory nerves that actually come from the muscle, the Golgi bodies that are there in the tendon. And when these Golgi tendon organs are suddenly stretched, they send a signal, and that is carried through the sensory nerve all the way to the spinal cord. And the spinal cord, through interneurons, they come out through the anterior horn. So these are monosynaptic reflexes. And we find that it causes contraction of the quadriceps and relaxation of the hamstrings, which results in the knee jerk. Now, in this, it's very important for us to know the simple fact that if any part of this network is affected, which would primarily be because of the nerves that are causing this network, there will be areflexia. However, if the muscle is affected to a certain extent, there will still be some amount of reflex present. Now, that's very important when we look at lower motor neuron diseases to differentiate between a primary muscle disease and neuropathy. In neuropathies, the nerves that supply the reflex, if they are affected, will cause early loss of reflexes, disproportionate to the weakness. Whereas in myopathy, the reflexes will be lost a little, primary myopathies, the reflexes will be lost a little later. Now, just to briefly summarize, so we have in our anatomy 10 points of localization. We have the brain, we have the cerebellum, the brainstem, spinal cord, anterior horn cell, roots, plexus, peripheral nerve, neuromuscular junction, and muscle. I have good news for you. There is nothing beyond the muscle. It ends at the muscle. So it's very important for us to keep all of these in perspective when we are looking at a patient who presents to us, be it in the emergency, where of course we have to make quick decisions, or it may be in the OPD, where we have time to work up these cases in detail. So all of these 10 parts of the anatomical localization are important. And each of them, as you can see in this table, have got certain parts which have very unique characteristics. So like we said, in the cortex, we looked at the homunculus and we saw how the homunculus is spread out over a large area. So if for the entire part of the cortex to be involved, there are very few diseases that can do that. And usually the entire cortex is not involved. So there will be a distribution in the body parts that are affected. For example, if the patient has got a stroke of the middle cerebral artery, then the middle cerebral artery supplies the lateral aspect of the brain. So they will have involvement of the face and they will have involvement of the arm, disproportionate to the involvement of the leg. So that is how we can differentiate cortical strokes versus subcortical strokes. Now, in the subcortical area, we have the basal ganglia, thalamus, and the internal capsule. Now, the internal capsule is a place where all the fibers are bundled into a small space. So if there is an infarct involving the internal capsule, the patient will have involvement of the face, arm, and leg equally. And that is what we call as dense hemiplegia. Similarly, if there's involvement of the meninges, that will cause headache, it will cause nuchal rigidity. And if there's involvement of the cerebellum, the patient will have primary problem with gait, with ataxia, not able to hold objects. Involvement of the brainstem, like we already discussed, they will have cranial nerve problems with long tract signs. They'll have crossed hemiplegia, which means that they will be at the same site of the lesion, there'll be a cranial nerve abnormality, depending on the midbrain or pons or medulla, whichever part is affected. And there will be a contralateral long tract signs, because like I said, the sensory and the motor, they decussate at the level of the for the anterior, for the spinal thalamic tract, they decussate in the spinal cord at the level. However, for the posterior column, they decussate at the sensory decussation, and for the pyramids, they decussate at the medulla, at the pyramids. So the tracts that will be affected will be contralateral long tract signs. In the spinal cord, the most important thing is the sensory level, like Dr. John mentioned, that in a patient who presents early in GBS, how can we differentiate between it being a problem in the cord or a problem in the nerves? Well, the sensory level is the key, and a detailed, careful, meticulous examination will tell us whether the patient is having a acute transverse myelitis versus a GBS in an early case. And of course, to look at the reflex level, the motor level, to see if there's any dissociative sensory loss. And reflexes may be increased usually, but early they may be absent, which is why there's that confusion. And the anterior horn cells are diseases that are purely motor, and they can have proximal and distal involvement, maybe asymmetrical. And because of their involvement, depends on which nerves are affected, the reflexes may be spared or may be lost. Similarly to that, the roots. However, in the roots now, the roots can be both sensory and motor, and you can have involvement of the autonomic nervous system also. The plexus, again, will have motor, sensory, and autonomic. Peripheral nerve, again, can have motor, sensory, and autonomic. And the neuromuscular junction is pure motor. The muscle will be purely motor. So this gives us a brief idea, and I'm going through this very fast, but most of these things, as you will think about it a little bit more and you will try to apply this, it will start making more and more sense to you as we see more patients in our career. Coming back to the three parts of the clinical diagnosis. So we have done our anatomical localization, and then we will discuss briefly syndromic diagnosis. So syndromic diagnosis again is based on anatomy. So your syndromic diagnosis has cognition, which is basically to do with your capacity to understand your environment around you and yourself, your capacity to reason, your capacity to be who you are as a human being. And then you have syndromic diagnosis based on your cranial nerves. So you can have monocular visual loss or binocular diplopia. Different syndromes are there. And your motor syndromes, which could be quadriplegia, hemiplegia, paraplegia. You can have sensory syndromes, hemianesthesia, or distal sensory loss, or dissociative sensory loss, or you can have autonomic involvement with bowel, bladder. You can have movement syndromes, like you've seen patients with Parkinson's disease. You have patients with hypokinetic movement disorders, and you have patients with hyperkinetic movement disorders. And then, of course, you have patients with headaches, patients with loss of consciousness. So coming on to cognition, we know that we have essentially four lobes, and the fifth lobe we could call the limbic lobe. So the frontal lobe, which is the largest lobe in human beings, and there's a dominant difference between human beings and primates, is the size and the dominance of the frontal lobe. So the frontal lobe has a significant role to play in executive functions. Most of these other lobes mainly receive information, and it's all directed inwards because they are mainly sensory and they process information. And the frontal lobe is the only lobe that actually gives information out, where the motor system, the motor part is here, the primary motor cortex, and then you have the prefrontal cortex, and you have the eye fields, you have the speech area, language area, or Broca's area. So all of these are outward and help us interact and express ourselves in different ways. So the frontal lobe has a behavioral component, significant behavioral component to it. So if it's affected, you will have behavioral problems. And if it is an acute thing, then acute stroke affecting the frontal lobe, you can have symptoms of acute behavioral problems. You can have speech and language disturbances. You can have involvement of motor weakness affecting the contralateral half of the body. So the temporal lobe is to do mainly with hearing and memory. So verbal memory, and it helps us to even hear, even for music, it is very important. Similarly, the parietal lobe is very important for primary sensory modalities, and also for calculation, and also for hemispatial our arrangement in space, visuospatial orientation. And the occipital lobe, we know, is to do with vision and to do with interpretation of things that we see visually. The limbic lobe is a lobe that has to do with our emotions. So anything that can affect these lobes will manifest in some syndrome, which we will be able to localize as to which part of the brain is getting affected. Coming back to the cranial nerves, like I said, that there are 12 pairs of cranial nerves. Each of these cranial nerves, the 1 and 2 cranial nerves, are above the midbrain, above the brain stem. 3 and 4 are part of the midbrain. 5, 6, 7, and 8 are part of the pons. 9, 10, 11, 12 are there part of the medulla. And you can have diseases that affect either of them singularly, or you can have combinations in series. So we know that there's a local thing that's affecting all of them together. We look at whether it's intraaxial, which means whether they are part of the brain stem. So then there will be involvement of the cranial nerve, but along with that, the tracts that are traveling alongside them will also be affected, and we get crossed crossed disturbances with ipsilateral cranial nerve involvement and contralateral long tract signs. Motor symptoms, we can have hemiplegia, which can cause complete weakness, or paresis, which is incomplete weakness. We can have mono involvement, which is one limb can be affected, any of the limbs, or we can have hemi, which would mean that half of the body is affected, or we can have paraplegia, which means that the lower limbs are specifically affected. And all of these syndromes will point to a part of the neuroaxis that is affected. So having a syndromic diagnosis really makes it much more easier for us to think as to which part of that neuroaxis is primarily involved. Sensory, you can have hemianesthesia, you can have crossed involvement with the trigeminal nerve on this side, and then you can have hemianesthesia here, and then you can have a sensory level because of a cord involvement. You can have involvement like this because of a syringomyelia. You can have involvement like this, in which the patient is having glove and stocking involvement because of peripheral neuropathy, or patient can have a Brown-Séquard syndrome like this, where the patient has got dissociative sensory loss on the body, or the patient can have a nerve, isolated dermatomal nerve involvement, or it can be an isolated nerve involvement as well in the sensory patterns. Autonomic involvement, you can have sweating problems, pupils, pupillary dilatation problems. You can have heart rate with tachycardia or bradycardia, blood pressure issues with difficulty in managing blood pressure, bladder, bowel, or sexual problems can be there. Movement, like I briefly discussed with you, you can have hyperkinetic and hypokinetic movement disorders. These are mainly to do with the basal ganglia and the cerebellum. And hyperkinetic movements could be, if your simplistic view would be that it is an excess of dopamine, and hypokinetic movements is because of a lack or a less amount of dopamine, which would cause Parkinson's disease and Parkinsonian sort of syndromes. Hyperkinetic movements would be like you can have syndromes of chorea, hemibalismus, or athetosis. All of these things can be seen. Blepharospasm, or all hyperkinetic movement disorders. Tics come in hyperkinetic movement disorders. Meningeal and CSF, you can have problems with increased CSF pressure, which could cause headaches, and the patient can have papilledema, visual obscurations for various reasons. And you can have decreased CSF pressure syndromes. Again, they can manifest with headaches, but in this, the headache would be more on sitting up. That's when they would have headache. In increased CSF pressure, it may be headaches which are more early morning headaches. And of course, if there's meningitis and there's inflammation of the meninges, it would be because of nuchal rigidity. Because of the inflammation, the patient will have Kernig's and Brudzinski sign that would be positive. So again, coming back to clinical diagnosis. So we have finished with anatomical localization briefly, syndromic diagnosis correlating with each of those anatomical localization. Coming on to the last part of this talk, which is etiological and pathological possibilities. Now, I like the number 10. So even for etiological possibilities, it's good to have 10 fingers. This is how I was taught by my teachers. You have degenerative diseases, you have congenital and developmental disorders, you have inflammatory disorders, neoplasm, vascular disorders, metabolic and endocrine disorders, drugs and toxins, which are extraneously ingested, taken in, nutritional, which are basically because of poor intake, or trauma, which can be sudden accidents or injuries. And of course, a special part here for demyelinating disorders, which happens mainly only in neurology. But these 10 fingers are applicable actually to all aspects of medicine, if you would try to look at it like that. Degenerative diseases, depending on the neuroaxis, which part of the neuroaxis are we thinking of, there are different diseases. And what do we mean by degenerative diseases? We basically mean these are diseases that are chronic. They happen over a period of time. There's no sudden surprises that happen in them. And these patients, they slowly keep degenerating. That part of the neuroaxis worsens. And there's really not much treatment for these diseases. So what are the diseases in this subgroup? You have in the brain, you can think of Alzheimer's disease, Parkinson's disease, Huntington's disease, which all have symptomatic management but really don't have a cure. And then you have brainstem and cranial nerves. You can have spinocerebellar ataxia. In the spinal cord, especially in the anterior horn cell, you can have amyotrophic lateral sclerosis, hereditary spastic paraplegia. In the peripheral nerve, you can have diseases like the Charcot-Marie-Tooth or hereditary motor sensory neuropathies. The second part in the etiological things that we think of is congenital and developmental disorders. So disorders like muscular dystrophy, spinal muscular atrophy, spina bifida, CV junctional abnormalities. All of these can cause various problems, which are basically, occurs in the younger age group, and also they may be born with these symptoms. Now, coming on to important part, which is inflammatory. Now, why I say this is important is because these are potentially treatable things which we should not miss. So inflammatory are basically non-infective, and there is infective, non-infective and infective. So non-infective ones are SLE, which are autoimmune diseases, inflammatory bowel disease, rheumatoid arthritis, vasculitis. All of these things are non-infective inflammatory disorders. And infective are proteins. For example, these are infective protein particles, which can cause Creutzfeldt-Jakob disease. Viruses like HIV, HTLV1, rabies, dengue. Bacterial like gram-positive, gram-negative bacteria, mycobacterial, atypical bacteria. Fungus like cryptococcus or mucormycosis. protozoas like Naegleria, amoeba, or helminths like Neurocystis cercosis. So all of these need to be thought of when we are thinking of in patients. What are we trying to etiologically? Okay, we've narrowed it down to this part of the brain. This is what we think is happening. What is the etiology? And in inflammatory, we need to keep all of these things in mind and understand how they interplay with time and with exposure and with occupation and with the presentations, how each of these organisms are different from each other. Then coming on to neoplastic disorders. So you have primary tumors of the nervous system, gliomas, astrocytomas, medulloblastomas, which are primary tumors of the brain and spinal cord. You can also have neurofibromas of the peripheral nervous system, and solid tumors with metastasis to the brain, like, for example, lung, colon, breast. All of these can metastasize to the brain and have a presentation. And hematological malignancies like multiple myeloma, non-Hodgkin's lymphoma, ALL, CLL, paraneoplastic syndromes because of small cell lung carcinoma. All of these things are important to consider in every patient who comes to us with a neurological syndrome, and we're trying to, after we've done the anatomical localization, we consider what could be causing these problems. And then, of course, the vascular syndromes. Now, these are dramatic presentations that the patient has, and the patient can come to us with a sudden onset deterioration. And these are dramatic presentations in the emergency and can be very worrisome for the family. So what are the vascular syndromes or the etiological possibilities? We know that there are the venous, superficial venous system and the deep venous system. So you can have problems that cause thrombosis in the superficial venous system and the deep venous system. And there are various histories which are prone to, circumstances. For example, peripartum, you can have people for infertility, maybe taking medicines which can cause a prothrombotic state leading to a venous sinus thrombosis, or patient may have infections in the brain that is causing irritation and inflammation of the veins, causing thrombosis. So it's an important differential diagnosis to keep when a patient presents with a fairly acute symptom. And then, of course, we have the arterial disorders, which can be both hemorrhagic or ischemic. In the hemorrhagic, we have two types: the subarachnoid hemorrhage and the intracerebral hemorrhage. The subarachnoid hemorrhage is basically to do with when the vessels outside the brain parenchyma, they get ruptured, so they cause bleeding around the brain parenchyma, and the blood causes it deposits around these brain vessels and causes vasospasm. And of course, they can have a dramatic presentation which can even lead to death. And then you have the intracerebral hemorrhage, in which the bleeding takes place within the brain parenchyma and causes weakness of side of the body, of the face, and can lead to headaches. And also in subarachnoid hemorrhage especially, you can develop nuchal rigidity because of irritation of the meninges. And coming to the most common presentation of vascular disorders, that's ischemic vascular disorders, which we know can be embolic or thrombotic. Now, embolic can be from any part of the vascular system, from the heart all the way to the large vessels, the aorta, or the carotid arteries, the internal carotid artery, the middle cerebral artery. It can be anywhere. We call them artery to artery embolization, or it could be cardioembolic strokes. And of course, they can also be thrombotic, which are local vessel related problems and causing small vessel diseases. All of these things are possible. And the key thing to differentiate in all of this is minute sequence evaluation. This is a term which basically says that your history should be so good that you can tease out what happened within minutes of each other. That gives us a clue as to whether this is an ischemic or a hemorrhagic stroke. If ischemic, is it embolic or is it thrombotic? Because embolic strokes would have maximum deficit at onset. And these are clinical tips that help us to differentiate between these etiological possibilities. Coming on to metabolic and endocrine. So you can have acquired metabolic disorders or inherited metabolic disorders. So acquired metabolic disorders are hypo or hypernatremia, calcemia, hyperglycemia, uremic encephalopathies or hepatic encephalopathies are very common problems. You can have inherited metabolic disorders like Refsum's disease or Fabry's disease, and you can have endocrine disorders, Cushing's, hypothyroidism, hyperthyroidism, hyperparathyroidism, all of these which can affect the nervous system. And of course, extraneously ingested drugs or toxins like lead, arsenic, cocaine, alcohol, even antibiotics, or chemotherapeutic agents can affect the nervous system and the neuroaxis. Nutritional disorders, especially vitamin B, you can have problems because of vitamin E deficiency. Vitamin D come with a lot of fibromyalgia and pain, and other micronutrients can cause problems. So nutritional disorders need to be kept in mind. And trauma, of course, is another etiological possibility where a patient may have had, like we presented that case. Now, we don't know whether the patient had a head injury, whether the patient had a fall. That's not mentioned in that history, but he could have had a fall and he could have been having a subdural hematoma causing that presentation. Other possibilities are demyelinating diseases, in which we know that demyelinating disease can affect the central nervous system and it can also affect the peripheral nervous system. So in the central nervous system, they can be basically diseases that affect acutely, which we say less than 4 weeks, and they would be basically ADEM or transverse myelitis. ADEM is acute disseminated encephalomyelitis, and it's a monophasic illness. It happens once, and it should settle, should not increase beyond 4 weeks. It can be subacute, and if it is recurring more than once, then you would suspect, if it's a relapsing and a recurrent disease, it could be multiple sclerosis. Now, also, if the patient has a peripheral nervous system disease, this is not disease affecting the central nervous system. Now it's affecting the nerves peripherally. Then if it's a monophasic acute illness, then we call it LGBS, or acute inflammatory demyelinating polyradiculoneuropathy. And also, if it is prolonged beyond 4 weeks, we would call it subacute IDP. And if it is more than 8 weeks, then we call it CIDP. CIDP has usually got a fluctuating course and can go beyond 2 months into several years also. So these are your 10 etiological possibilities. So how do we differentiate between all of these? I think the key thing for etiological possibilities is to look at the duration, whether it's acute, subacute, or chronic. Now, acute itself would, like I said, 4 weeks, 4 to 8 weeks, 8 weeks and beyond, or even 6 months would be chronic. So different etiological possibilities will fit into them. And also to know whether it's a multiphasic illness or a polyphasic illness. And if it's a single phase, like I said, there will be diseases like ADEM or GBS in the peripheral nervous system. When there are multiphasic illnesses, then in inflammatory itself, there are so many diseases that can have waxing and waning courses. Now, acute can be several out of these. It could be trauma. Even demyelinating diseases can be fairly acute. Drugs, intoxication can be acute. Metabolic and endocrine problems, not very acute, but not a dramatic presentation like in vascular, like a bolt from a lightning, but they can have problems that develop over a few days to a few weeks. Similarly, inflammatory disorders also can be fairly acute or subacute or chronic, and usually these will be affected involving other inflammatory things like fever, or the patient may have pain, or other inflammatory markers will be there. And congenital, developmental, and degenerative disorders are usually chronic. Very few acute presentations of these, and these are mainly chronic. And the presentation is very important, whether it's acute from the beginning of the symptoms to the peak of the symptom is very important. That's what we call the onset. And if it is here, then it's probably acute, but if it is kind of increasing, then subacute, or if it's beyond 8 weeks, then it can be a chronic disease which is going to progress. And of course, whether it's waxing and waning type of disease, which will help us to differentiate between all of these 10 etiological possibilities. Now, again, this is our syndromic diagnosis. We have our anatomical localization, and we have the etiological and pathological possibilities. So coming back to our case, what do we know? Now, this patient is a 47-year-old man. He's an acute onset right-sided dense weakness, upper limb, lower limb, and face. I just made it dense with right UMN facial weakness. He's got global aphasia, which means that his temporal lobe and his frontal lobe is affected. That's why he's got global aphasia. He's got right homonymous hemianopsia. The clue was the fact that he was looking more towards his left side. He was ignoring the right side, which can be part of the neglect that he was having. But he was looking more, paying attention to things on the left side. And also at the same time, where would we now localize it? Well, we have evidence that his frontal lobe is affected. His because of the motor weakness here. We know that his global aphasia means frontal and temporal. The Wernicke's area is in the temporal lobe that's affected. He's got a right homonymous hemianopsia. Well, this could be part because of the internal capsule that is affected. But if it is the cortex that is involved, you should not have got upper limb and lower limb and face equally. Because, like I said, either both the anterior cerebral artery and the middle cerebral artery should have been affected. But suppose if it was only the middle cerebral, it wouldn't explain it. And most likely the internal capsule is also involved, which is why he's got hemianopsia and all of these findings. So now what is the possibility? I very carefully mentioned that it was a recent onset. I did not say it was acute. I did not say it was in a few hours or in a few minutes from being absolutely normal, he worsened. It was recent onset. So if it was progressing over a few days, we don't know, or if it happened suddenly. So, well, the possibility is that of a left middle cerebral artery stroke, which is affecting the cortex and the subcortical area, or it could be a left-sided space-occupying lesion that is affecting the frontal, temporal, and the occipital lobe with a lot of edema. It could be an abscess, or it could be a metastasis from a different part of the body, or it could even be a left hemispherical traumatic brain injury, like I said, with subdural hematoma. So, I would like to ask you, what when you heard that history, what was the first thing that jumped to your mind? And usually, when I would present this, people would think of stroke because that's what we're worried about, and that's the most common thing we come across. But it is important for us to think of other things and take a step back and go back to the history and ask, how acute was it? How sudden was it? And we might be surprised that it was probably over a period of time that the patient had these symptoms, and our diagnosis of stroke, even clinically, was wrong. Just in closing, I would like to just share a few things on pitfalls in diagnosis. Very often we are all short of time, and we are rushing for from one patient to the other. So there are certain known and documented pitfalls. So there's the framing effect. The framing effect is basically when your junior would frame the clinical case in a particular way, and we get swayed by the emphasis that is being put on certain parts of the history. So that is the framing effect, and there are ways that we can protect ourselves from that. Second is the anchoring heuristic. The anchoring heuristic is basically, when we see a patient, we make an initial impression, and we make a quick diagnosis, and we are fixated on that particular thing, and we might miss the real diagnosis if we are not able to move out and take the whole clinical picture into perspective. And the third is availability heuristic, in which basically based on the number of cases we have seen in the past, we would tend to recall certain cases which have made an impression upon us, and we will try to say that this is the same case. And the representative heuristic, in which basically we look at not the frequency of various differential diagnoses that are presented, but we kind of fall into a trap of looking at what it grossly looks like without going into the details. And finally, of course, blind obedience, where because senior says so, so we believe it, instead of actually trying to question it and looking for the right diagnosis. So Fisher's rules are basically the 3 or 4 important things that I would like to mention. In arriving at a clinical diagnosis, think of the 5 most common findings: historical, physical, or lab. They're found in a given disorder. And if at least 3 of these 5 are not present, then the diagnosis is likely to be wrong. Resist the temptation to prematurely place a case or disorder into a diagnostic cubbyhole that fits poorly. And allowing it to remain unknown stimulates continuing activity and thought. And this is cannot be emphasized more. It's a very important part of clinical diagnosis. When it is not making sense, keep digging. Don't settle for whatever diagnosis suits you, but keep digging for more information. And the details of a case are important, and the analysis distinguishes the expert from the journeyman. And pay particular attention to the specifics of the patient with a known diagnosis. It will be helpful later when we see similar phenomenon, especially when sometimes diagnosis cannot be made in that particular sitting. And accept what you have heard and read only when you have yourself verified it, and maintain a lively interest in patients as people. So for students especially, when several of the main features of a diagnosis in its typical form are lacking, an alternate diagnosis should always be entertained. That's very important, because one is more likely to encounter rare manifestations of common diseases than the typical manifestation of rare diseases. And should the disease be in a stage of transition, which very often happens in neurology, time will allow the full picture to emerge, and the diagnosis will then be clarified. And students tend to err in failing to recognize a disease they have not seen, and experienced clinicians may fail to appreciate the rare variant of a common disease. So for students especially, the more you see patients, the more you attend clinics, and the variety of cases that you see, you will be well armed to be able to make a better diagnosis. Thank you very much.
Thank you, Dr. Jason. It was really a wonderful talk. I'm sure all our students have benefited a lot from this beautiful scheme of the discussion. And I would like to request the participants to, if you have questions, to send more questions so that Dr. Jason can discuss. We have at least 2 or 3 questions now. One is how to differentiate arterial versus venous stroke. Dr. Jason, please.
Okay, so we know that arterial strokes are very sudden. They are, if the artery gets blocked, then the blood supply distal to that is immediately cut off. And because the brain cells need blood supply for oxygenation and for its metabolism, there is an immediate dysfunction that sets in. In venous strokes, however, the onset is a little bit less dramatic. And let's say, for example, the superior sagittal sinus, which is very often the one that gets thrombosed. In that, what happens usually is the patient first develops a headache. Following the headache, the patient may actually have a seizure because of the cortex getting irritated. And also following that, the patient may develop with weakness. Often the weakness may be the lower limb, where because the sagittal sinus is medially placed, sometimes patient may have lower limb involvement, which may then progress over a few hours to a few days to involve the rest of the limb or that area. So clinically, this is how you would differentiate arterial strokes from venous strokes. And also probably in the context, if the patient is in a prothrombotic state, or patient has been peripartum patients, like I said, on for infertility drugs, or patient has a hypercoagulable state, all of those would also weigh in.
Another question, Dr. Jason, is why neuromuscular and muscle disease affect predominantly proximal than distal, by Dr. Sujit. Probably we can add that radiculopathies also have a predominantly proximal weakness.
So I didn't have time to actually go into this in much detail, but the nerves, I think, are fairly easy for us to understand. Let's begin with the nerves. In the nerves, we know that the axon supply that takes place begins from the neuron, and it's from the neuron that the supply goes all the way along the axon distally. So many neuropathies are length dependent. And because they are length dependent, what happens is that you develop glove and stocking affection when patient has got neuropathies. In patients with muscle diseases, however, there's a difference because of the large bulk of the muscles that are proximally situated. So patients with muscle diseases have more predominant affection of the proximal group of muscles, and the axial groups can be affected. Now, there are muscle diseases, muscular dystrophies that can be affected distally, but that is, of course, rare, and dominant muscle diseases affect proximal muscles for the very same reason that there are large bulk of muscles proximally.
Dr. Vineet, there are a lot of congratulatory messages and thank you messages from many of our participants. Dr. Renji has commented about you, our surgeon. Carmel Martin is mentioning that thank you, and she says this is very good and very informative class. And one more question is, in case of trauma, how will we assess the patient?
Well, I think trauma, the history is very critical. They can have presentations that are similar to stroke, but trauma, the history, and also external injury that the patient has will give you a clue whether the patient has suffered trauma. And also, of course, clinically, it may not, after that, beyond that, is difficult for us to assess. You need radiological assistance to see if there's any fracture underlying the brain, in the skull, and if there's any fracture that is there, and the kind of injury inside the brain, whether it's an SDH, which is not a stroke, or if the patient has got any contusions. Those will give a clue that the patient may have suffered trauma, and this may not be acute stroke if the history and the clinical examination does not point towards trauma.
Can you explain 1.5 syndrome?
Okay, so 1.5 syndrome is a syndrome that affects the brain stem. And for that, I would like to draw. I don't know if you'll be able to do that. But basically, 1.5 syndrome, you need to understand the horizontal eye movements. So the horizontal eye movements begin in the frontal eye fields. So let's say, for example, let me see if I can do it here. So if this is my left frontal lobe, my left frontal eye field is connected to the right side pons. Okay, so my left is connected to my left pons through the PPRF, and the PPRF then signals the sixth nerve nucleus on my right side. So this is stimulating, and my eyes will turn towards the right side. Because the sixth nerve nucleus here is connected, also at the same time, the medial longitudinal fasciculus is connected to the midbrain. In the midbrain, you have the medial rectus there. So they are all connected. So this is signaling here, and this is connected to the midbrain. So when this fires, my eyes move in this direction. So in 1.5 syndrome, what happens is there is affection of the pontine nucleus. The pontine nucleus of the sixth cranial nerve along with the medial rectus gets affected. So the patient now is not able to do this. And also when the patient is looking to this side, what happens is that the patient is not able to completely look onto the right side. So the patient has got a complete involvement of the sixth cranial nerve and the medial longitudinal fasciculus, which prevents the patient from completely looking to this side, because the medial rectus on this side is also affected. So only the lateral rectus is what's free on the opposite side.
Dr. Tarakarian has asked, does GBS have a muscle predilection, like proximal or distal?
So like we mentioned, any neuropathy, if it is length dependent, will be distal. But GBS is actually a radicular neuropathy. So because of involvement of the roots, and roots we know can affect proximally and distally depending on which part of the body is getting affected. So you will have the roots affecting the proximal part can cause a proximal weakness, whereas the nerves and the roots affecting distally can have distal weakness. So they can present with both proximal and distal weakness.
There's a comment. So the advent of neuroimaging, especially MRI, is it worth spending so much time in taking a history and examination, easily taking more than an hour, rather than see the patient problem probably somewhere in the CNS MRI, then see?
No,
So
I think that's a very good question, and I think this is what like I said, see, in the emergency department, the way we operate is very different from the way we operate in a clinic. So very often, patients come in the emergency, they are unconscious. So we are saying, okay, reticular activating system involved, central nervous system involved, get an MRI done. The MRI done, it comes normal. So then we start going back and digging the history and finding out what happened. And we realize that the patient had overdosed on benzodiazepines and nobody had checked the pupils to see that the pupils were constricted. So definitely a good history may not be possible in the emergency situation, and everybody is forgiven for that. But in the clinic, when a patient comes to us, I think it's very important for us to take a detailed history, a relevant history. It doesn't have to be 1 hour. It is usually 1 hour because we don't know what we are looking for. But the patient's symptoms, if they say they have these problems, the chief complaints itself will narrow it down. And you just want to cursorily look at other neuroaxes if they are involved or not. And then it helps you to focus your imaging. More, I cannot emphasize how many times, because of a poor history, there's wasteful investigations done. MRI is not cheap. And, I've seen patients, they'll say, screen the whole spine, do MRI brain and the whole spine. And that's, that's like almost 20,000 rupees or more than that, when they could have just done a detailed examination and narrowed it down to which part of the neuroaxis is being involved. So there is definitely a role of detailed examination and history. Yes.
And quite often we will be misled by the incidental findings in the MRI, so that the relevant diagnosis will be missed actually.
Yes.
Dr. Jason, also in India, we have a lot of patients coming to our OPD, and neurological examination and history taking sometimes ideally will take a lot of time. So what is your advice to our youngsters regarding taking a focused history and going in for a focused clinical examination in a busy practice in the OPD?
I think your training is very important, and that is what is going to save you. If your training in those days of of intense training, we try to cut shortcuts, there is no hope. So the only answer is to see as many patients while in training, do detailed examination of all your patients, and that will help you to recognize patterns. So when the patients come to you in the clinic, you may not need to spend that much time. Without that, I really don't think there is any clue that I can give you. It is a lot of hard work, a lot of discipline, and training your mind. Once your mind is trained, really, as the patient walks into your clinic, you're already ticking off many things. As you're taking the history of the patient and the patient is speaking to you, you're checking off so many boxes, and it's unconscious. You don't even realize it that you're doing it. But finally you narrow it down to, okay, what are the signs that you will not be able to pick up? So one of the things may be ataxia. Unless you look for it, you may miss it. There are certain things like that which you must examine and you cannot avoid. So, but yeah, I think your training is very, very important, and please invest time in examining patients thoroughly and taking detailed history and seeing a spectrum of cases.
Jason, today we had a lot of participants, and I'm sure this was a very interesting session. So more and more questions are coming. I think I will take one more question now because of lack of time. When you mentioned about pattern recognition, how do we differentiate various muscular disorders? One question.
So muscular disorders are a very, it's an area I'm very interested in, so I could talk for it for a long time. But muscular disorders as such, you must understand, if they are primary muscle diseases because of inflammation. Let's say, for example, you have a condition called polymyositis. So in polymyositis, there will be more of proximal involvement of the muscle, which means you will have shoulder and hip girdle muscles that are more affected, but all the groups of the muscles will be affected. So you'll have hip flexion, hip abduction, hip extension, hip, hip adduction. All of them will be affected in polymyositis. Now, if you come to muscular dystrophies, now these are structural problems in muscles. In that, there is selectivity of muscle groups. So you don't get all the hip girdle muscles involved like that. but certain muscle groups will be preferentially more involved than others. And that tells us that this is muscular dystrophy most likely. Also, like I said, the chronicity of the disease. If it's a fairly acute disease, then it could be drug-induced problems, or if it is a chronic disease, then it could be diseases that are genetic, or they could be, chronic diseases that affect the muscles, myositis or myopathies. That is one thing. Another important differential, like I told you, in the spinal reflex is the presence or absence of reflex. Now, that's very important. In patients where the reflexes are absent, then very likely it is not just a primary muscle disease, but there is also a neuropathy existing or coexisting with it. So we need to be very thorough with that. For example, in patients with muscular dystrophy, you may have absent reflexes in the upper limbs and the lower limbs, but your ankle jerks are very well preserved. So we know that this is not a spinal muscular atrophy in a child, but this is most likely a muscular dystrophy. So there are clues like that which help us differentiate in muscle diseases. Also, like I said, you can have facial involvement in facioscapulohumeral muscular dystrophy. You can have scapuloperoneal involvement, proximal in the upper limb, distal in the lower limb. You can have limb girdle muscular dystrophies. So these patterns are there, which are well described, which help us to differentiate between muscular disorders.
So I think we'll conclude today. Dr. Jason, it was a wonderful talk, and I'm sure all of our students have enjoyed it really. Thank you very much. I hope in future we can have more sessions like this.
Thank you so
Thank
much.
you for sparing your valuable time for us. Thank you so much. Over to Dr. Jacob for concluding remarks.
Dr. Vineet, that was an amazing talk. Really awestruck with your presentation and the way you went about it. I really believe, and it's quite evident that all the students and delegates who have participated would have really benefited from your sessions. Thank you so much. And as John sir said, we would really love to have you for more sessions in future. We would treasure you as an amazing resource person. Thank you so much.
Thank you very much.
Thank you.
I know it's a very tough time, COVID and all that, and you would be having a really hectic schedule. And thank you so much. In spite of that, you have come over, you're prepared so well, and you have imparted this for us. We are really grateful.
Thank you very much.
And I would like to extend my thanks to Dr. John sir also, our professor and head at neurology. Sir, you have spared your precious time to be part of this program, and you've moderated the session admirably. Thank you so much, sir.
Thank you, Dr. Jacob. Thank you for inviting me and allowing me to moderate this session. Thank you. I really enjoyed listening to Dr. Vineet. Thank you so much.
Thank you so much, sir. And my special thanks to all the delegates here. And I can see you guys pouring in your gratitude for that session. And I think Dr. Vineet is looking at it live, and he has a good smile on his face. And thank you, guys. Thank you for coming in. And my special thanks to all the new participants from Tamil Nadu and other colleges in Kerala and elsewhere. So welcome, dear students and postgraduates and everybody from other states also. We are conducting 2 national and international webinars every week where we have luminaries speaking to you. So don't miss these sessions. Please do log in. It's totally free and it's out there for you. And also we have another series called Believers Undergraduate Clinics and Believers Postgraduate Clinics. So that also we invite you to be a part of, and come on in, participate, listen, ask questions, and enhance your knowledge. So until we come back to you with another very good session, we sign off from Believers Church Medical College and Hospital. Thank you so much. Have a very good evening. Thank you.
Thank you. Good night.